Hello and welcome everyone to our journal review for the month of April. The first study is a RCT between standard respiratory therapist assessment tool versus an automated continuous monitoring alert, which was then used to initiate a respiratory therapist's intervention. In this RCT, they found no difference between the two systems, and thus they concluded that an automated system can be used to replace a continuous presence of standard respiratory therapist at the bedside in managing post-extubation failures in the ICU. The next study is a study published in JAMA in pediatric age group. It compared high flow nasal oxygen with continuous CPAP following extubation from liberation from respiratory support. In this, they had around 600 patients, 312 boys, 241 girls, 301 randomized to the CPAP group, 299 to the HFNC group. The study was conducted in UK. The primary outcome was time from randomization to liberation from respiratory support assessed against a non-inferiority margin of a hazard ratio of 0.75. In this, they found that HFNC was compared with CPAP failed to meet the criteria of non-inferiority. Next is a meta-analysis between video laryngoscope vis-a-vis direct laryngoscope for adults undergoing tracheal intubation. Video laryngoscope of all designs were likely to reduce the rates of failed intubation and result in higher rates of successful intubation on first attempt with improved glottic view. Macintosh style and channeled video laryngoscope likely reduce rates of hypoxemia events, while hyperangulated ones probably reduce the rate of esophageal intubation. Thus, they concluded that video laryngoscope likely provides a safer risk profile compared to direct laryngoscope for all adults undergoing tracheal intubation. The next study is a comparison of central venous to artery CO2 difference guided hemodynamic management in major surgery, an RCT comparing it with the placebo. So 100 patients were randomized and the blood gas were collected. Intervention group, the assessment of both the values were managed per protocol based on the TCO2 and HCVO2, resulting in a dobutamine infusion of 3 to 5 microgram per kg per minute started if the TCO2 was more than 6 millimeter per Hg after correcting for all microcirculatory endpoints. Now, the control group used only the ABG and managed it by the conventional goals. Now, patients were followed for 48 hours after surgery, and organ dysfunction SOFA scores were the primary outcome. In this, they found that the GDT guided by the TCO2 did not improve organ function in the cohort of patients they used, that is major surgery. It resulted in a greater use of dobutamine, improved tissue oxygen parameters, and decreased length of ICU stay. Thus, more evidence is required for routine use of TCO2 in sicker patients. In absence of cardiac output monitoring, it may be used as a less expensive parameter in major surgical procedures. The next is a COVID-19 study of defibrotide. This is basically a compound which is polyanionic in nature, fibrinolytic, antithrombotic, and anti-inflammatory properties. The research question was the safety and tolerability of this drug in severe COVID-19 patients. They included 12 patients and they found that the use of this drug was safe and tolerable. No hemorrhagic or thrombotic complications were reported. The next is a study between early versus standard tracheostomy in ventilated patients in neuro ICU. This is a RCT done in Malaysia. They assessed 42 patients, 40 were randomized, 20 in each group. And in this, they found that the day of ventilation before tracheostomy was 3 and 8 as per protocol. And in this, they found that there was better outcome if the patient underwent early tracheostomy. Now, long-term outcome of dexamethasone, that is 12 milligram vis-a-vis 6 milligram in patients with COVID-19 and severe hypoxemia. Now, this is a follow-up study of a study which has been published previously. They looked at the quality of life. So nearly 460 patients in both the groups, and they found that the quality of life was almost similar. So there was not much difference in terms of quality of life in terms of dexamethasone, 6 milligram and 12 milligram. The next is tranexamic acid in patients undergoing non-cardiac surgery. They included almost 9,000 patients with the primary outcome with a composite outcome of individual bleeding risks. And in this, they found there was a significantly decreased bleeding, that is 9% versus 11% in tranexamic group. So as you can see, there was a superiority of tranexamic acid over the placebo. The next is the quality of life in ICU patients discharged with COVID-19. This study basically took the data from the Fragiria trial and compared it with the other control group, and in this they found that there was not much difference in the quality of life. COVID-19 patients surviving ICU stay do not have a worse outcome than regular ICU patients. However, further studies, including large cohorts followed up for longer duration, is required to confirm these findings. Now, next is a closed loop oxygen control, which improves oxygen therapy in acute hypoxemic respiratory failure undergoing high flow nasal oxygen. That is the HILOOP study. In this, 68 patients were assessed for eligibility, out of which 45 were taken in the final analysis. Here you can see that the closed loop analysis resulted in less variation in the use of oxygen, and here also you can see that closed loop result in more optimal SpO2s compared to manual oxygen titrations. So thus they concluded, after looking at the primary outcome, which was statistically significant, that closed loop oxygen control improves oxygen administration in patients with moderate to severe acute hypoxemic respiratory failure treated with HFNO.